Grossing. These are my disclaimers. Now, from the basic anatomy, breast is basically a modified sweat gland that lies from the lateral sternal border to the mid-axillary line and from superior to inferior from the second to sixth rib. And basically, the breast structure is that it is composed of, if you can see, I'll just use the pointer. Yeah. So you can see that it is composed of various lobules all draining into lactiferous ducts that end on the nipple. And these lobules themselves are composed inside of multiple acini, which are surrounded by connective tissue and rest on adipose tissue, which is the supporting structure of the breast. Now, this breast anatomy has been kind of iatrogenically or artificially divided into multiple quadrants, as we are all very familiar, as the upper outer, upper inner, lower inner, and the central quadrant, and the axillary tail of Spence. But it is very important to remember that these are not actual anatomical landmarks. These have been created by us for ease of description and basically to identify as an identifier in which area we are seeing some lesions, but these are not actual anatomical landmarks. So tumors actually do not follow this, do not follow these lines that we have artificially drawn. So you can, and the lobules also inside the breast, the lobules can be extending from here to there in any direction and do not follow the anatomical. There is no fascia dividing these different quadrants. So this is important to remember, because the breast, otherwise lobules are quite irregular structures and do not follow any otherwise and other anatomical landmarks. So, and the reason that majority of the lesions or tumors occur in the upper outer quadrant is that this is the area where majority of the lobules are located. And it is basically, as I said, it's a modified sweat gland. So it is composed of highly specialized apocrine glands, which have epithelial and stromal component. And it is a three-dimensional structure, all terminating, the lobules terminating into ductules, which terminate from the lactiferous sinus onto the nipple. And the main functional unit of the breast is basically what is known as a terminal ductulo-lobular unit, TDLU, which is the functional unit for lactation, in which you have multiple acini which form a lobule which drains into a ductule, which further drains into larger lactiferous ducts. So this is the basic unit of the functional unit of lactation, and majority of the lesions we see are associated with this TDLU architecture. So it is composed of a basal layer of inner layer of tubular cells and a outer layer of myoepithelial cells. So bilayer composed of epithelial cells and myoepithelial cells, which rest, if you can see here nicely, which rest on a basement membrane and are surrounded by what is known as the stroma of the breast. So this is on high power, you can see a bilayer structure. This is the inner tubular, cuboidal, luminal epithelium, the epithelium. And here on the outer side, you can see there are clear cells with dark nuclei, which is basically the myoepithelial layer or the contractile layer which surrounds these tubules. And there is you will be going through the various classes in which you will get to know that we need to identify these luminal and abluminal or myoepithelial cells by various markers. So what are the normal markers? For the luminal epithelial or layer, you have cytokeratins, which can be mainly we use CK7, but otherwise there are other ones like 8, 18, 19, CK5, 6. These highlight the epithelial layer. They show classically heterogeneous ER/PR expression because they are responsive to hormones. The breast is a hormonally active gland, and it is responsive to hormones. And because the expression of hormones differs in different type of cells, that is, normally we have a polyclonal distribution of cells inside the breast. So you see a heterogeneous ER/PR expression. And as you will see in subsequent classes, this normal heterogeneous expression of ER is important to distinguish from abnormalities. Besides this, these epithelial cells also express GATA3, TRPS1, which are considered the markers of breast. They also show membranous expression of E-catenin and beta-catenin, and also cytoplasmic expression of proteins called mammoglobin and GCDFP15, which sometimes help to identify whether the lesion is of the breast origin or not. In addition, we have besides the epithelium, we have the myoepithelial layer, as I said, which is the outermost contractile meshwork. And this can be highlighted by basal keratins, such as high molecular weight cytokeratins, CK5, 6, 14, 17, or a lot of other markers like the smooth muscle actin and calponin, which are more commonly available in most labs. Besides this, the P63, S100, CD10, these can be present in the myoepithelial layer. So basically, you will be seeing in different this thing that classes that loss of this myoepithelial layer is important to diagnose certain lesions, especially invasive carcinoma. So how does this look like? Generally, we put a nuclear marker which highlights the nuclei of the myoepithelial cell and a cytoplasmic marker, so that we can do when the lining is attenuated, at least one of the markers will pick up the lining. So at least two markers are put at a time. Besides this, what do you have? The third component, as I said, was the stroma, the epithelial, myepithelial, and the stroma. Now, the stroma is also hormonally responsive. So, it is also usually ERPR positive, and it can show scattered ERPR expression, and it also positive for CD34. And there are two types of stroma in the breast. One is the interlobular stroma. Now, this is one lobule, this is another lobule in between the stroma, but it is still within the TDLU unit. This stroma, and the stroma that is just surrounding the acini within the TDLU. This is loose with macrophages, fibroblasts, it has inflammatory cell. This loose myxoid stroma is the intralobular stroma, and this is also hormonally responsive. Now, this is the other structure in the breast. This is the nipple areolar complex. It is important for you to see that how a good taken section, you can see the whole architecture of the nipple areola from you can see the ending of the terminal ducts and reaching up to the skin. This is actually also a very good section in which not only the nipple areola, the terminal ductal lobule units, but also the muscle that separates the nipple from the underlying subcutaneous tissue. You can make out this muscle bundle of muscles over here. So this is the basically the differentiating line between the stroma of the nipple and the underlying subcutaneous tissue. And this again, as you can see, the terminal ductal units form lactiferous sinuses which drain onto the skin, and normally these sinuses are usually collapsed. So you see star shaped structure and not dilated ductules. And the stroma of the nipple also has abundant smooth muscle because it is contractile. It has abundant smooth muscle in the stroma, and it is important to recognize that this is smooth muscle in the stroma and not nerve, because many times people mistake these smooth muscle bundles that are present in the stroma as well as at the base of the nipple from nerve bundles. So you can see the difference, that this is a nerve bundle which is enveloped by a perineurium, and right next to it here you can see that these are smooth muscle bundles. So this should not be mistaken for the nerve bundles, and you can call a tumor which is infiltrating the muscle of the stroma and thus entering the dermis of the nipple. You may end up calling it as perineural invasion. So the structure of the nerve, which is the basic histology, versus structure of the smooth muscle of the nipple, you have to keep in mind. And this is the normal architecture, that you will have muscle at the base of the nipple areolar complex, which will be missing if the section is from the overlying skin. Now, overlying skin will be having the histology as anywhere else in the body, except you might see more sebaceous structures. And even if it is on the deeper side, you will not see the smooth muscle bundles as I showed you, which basically tell you that the section is somewhere from the nipple areolar complex. So this is just the basic histology. And if I have, I think, some questions so far. Parul, can you just tell me if there is a question so far?
Yes, ma'am, there's a question. What's the difference between accessory breast and axillary pad of fat?
Sorry, accessory breast and?
Axillary pad of fat.
So axillary tail of Spence is, I think, what is distinct.
Yeah, that
Accessory
I
breast. Accessory breast can be present anywhere extraneously outside in the from the mid axillary line to the sternum, which can be as a separate lobulated axillary structure away from the breast. While axillary tail of Spence is, as I showed, is the extension of the breast tail entering into the axilla. So it is in continuity. While accessory breast is usually where during development you might have a rest of from migration, the migration stopped, and you have a rest of breast tissue away from the breast structure. That is the anatomical location, as I showed, of the breast. It is away from that. So that is accessory breast. So we start with the breast grossing. So the type of specimen we receive in the surgical lab, basically in cases where there is a palpable mass and it is small in size, it is possible to excise. We get wide local excisions or lumpectomies. When there is impalpable mass or only radiological abnormality, wire localized or sono-localized excisions can be done, but these are done only mostly at specialized centers. Then you can have microdocectomy, revisions, re-excisions, and the major specimen that is a lot of people see is the mastectomy. Now, mastectomy is also of multiple types. These days, there are also prophylactic mastectomies as information for genetic counseling is getting prevalent. A lot of people opt for prophylactic mastectomies also. But main concern for a grossing is the therapeutic mastectomy, which can be simple, MRM, radical, or different types of cosmetic alterations which have been done for preserving the cosmesis. Besides this, you have completion mastectomy and reduction mammoplasty. So I'll be going through the most common specimen that we see, that is the simple mastectomy. Now in the simple mastectomy, basically the extent of excision vertically is that if the breast is excised above, in the fascia above the pectoralis muscle. From the pectoralis fascia, the breast is lifted off. It is the simple mastectomy, and it usually is accompanied by an ellipse of skin and the nipple complex. And if you have axilla attached to it, it is called a smack or a simple mastectomy with axillary clearance. If the vertical extent is that the mastectomy is taken through a bit of the pectoralis muscle, at least the superficial part of the pectoralis muscle is also included, it is called a modified radical mastectomy. And if the complete pectoralis muscle is lifted off from the chest wall, it is called a radical mastectomy. In addition, these days for cosmetic purposes, you have the skin sparing mastectomy, in which if the tumor is far away from the skin, there is an attempt to remove as little skin as possible so that cosmetic reconstruction can be done in the same sitting. Or you can have a nipple sparing mastectomy, in which if there is a deep seated tumor, they try to preserve as the skin of the nipple also. So all you have is the mastectomy without any overlying skin and a stitch to indicate where the nipple areola complex was. So these are the various types of mastectomy we receive routinely. And what type of procedure? Basically, there are a lot of factors that determine what procedure is going to take place: the size of the tumor, the location, the aggressiveness, the receptor status, the focality, the patient related factors, and of course patient choice. And to help us pathologists in delivering a reproducible report which has the essential features which are required for managing the patient, there are a number of guidelines in histopathology reporting for performa from the College of American Pathologists, Royal College of Pathologists, the AJCC, and most recently the ICCR, International Collaboration on Cancer Reporting, which has combined a lot of these guidelines into one single document. I would urge all of you to go through the ICCR data sets of the breast. These assist the pathologist to provide a useful, comprehensive, and complete report, not just for accurate staging, so that or for the also for the management of the patient, and is based on the best available evidence. So this is the current ICCR data set for breast cancer reporting, which has a lot of core and non-core parameters. We will cover most of these parameters in subsequently. So from my first years waiting for questions, the first question I would like to ask is from Divya Shri. How much is the fixative relative to the specimen which is ideal? Divya Shri, can you hear me?
Yes, ma'am. 10
Yeah.
times, it should be 10 times of the
10
specimen
times
size.
the volume of the specimen in the container. In the container that you have kept the specimen, 10 times the volume of the specimen should be the amount of fixative. So is that done everywhere? Is it followed? Is it followed in all the hospitals? The other students also,
Um,
does everybody do it? So actually, that is a problem that we say that it is ideal, but it is not practically followed. It is easy for smaller biopsies to have containers in which you have 10 times the volume of fixative, but majority of the time, the specimen is just lying in a big, a jar with hardly anything. It is covering, taking up the whole space. It is stuffed into a small bag or a container or jar and just sent to the path lab. So it is our job to take it out from that and put it in a larger volume container in which we will be able to put adequate fixative. And if not 10 times, minimum 4 to 5 times you should put the fixative. Okay. So now Kasturi, can you tell me how much is the cold ischemia time as per the ASCO-CAP guidelines? Kasturi, are you there? If not Kasturi, can Ria or Pratiksha, who are there, can anybody answer? How
Yes,
much is the
ma'am.
cold ischemia time?
It's less than 1 hour.
1 hour.
Less
As per
than 1 hour.
ASCO-CAP.
What is
Yes.
cold ischemia time?
It is the time between tissue removal from the body and placement in the fixative.
Perfect. So the time when the specimen has been excised from the patient body and the blood circulation is stopped, that is when the cold ischemia time starts, and the ideal time within which the specimen should be properly put in fixative is less than 1 hour. So this is actually this is something that you need to convey to your surgical colleagues, that the specimen should not be left lying around. It should be put in formalin as soon as possible and dispatched to the lab. And how much is the ideal fixation time as per the ASCO-CAP guidelines? This is for FOD.
Ideally, it's 6 to 7. It should be get fixed.
So does this include the time it has reached the lab? Does this include the time it is in the machine? Does this include the time it is lying overnight in the lab?
Actually, the time we place the specimen in the formalin,
Hmm.
it will
Yes.
increase those time.
So the time starts from the time it is placed in formalin. So ideal
Yes.
time less than 1 hour of cold ischemia time, place in formalin, and from that time the clock starts. And minimum 6 hours. Is not that it has reached your lab fast, so you have to process it fast and put it for the into the machine. You have to allow sufficient time for it to be fixed properly, minimum 6 hours. And in larger specimen, it is ideal to be, give it some more time. In smaller biopsy, 6 hours is fine, but in larger specimen like mastectomies, it is ideal to let it fix overnight and then process it next day so that there is adequate fixation. Okay, 6 to 72 hours. 6 hours is okay for small biopsies, but for larger specimen, it would be better to have at least an overnight fixation, but not beyond 72 hours also. Okay. So these are the general principles of grossing. As I said, the fixation time is extremely crucial. Yeah, can anybody tell me for why is the fixation time crucial? So fixation time is crucial because this is, we are not just giving a diagnosis, we are also doing downstream testing for biomarkers. And for those biomarkers to work properly, we need proper fixation. If it is underfixed or overfixed, the biomarkers do not work properly, as well as molecular testing does not work properly if subsequently the patient requires molecular testing. So both for immunohistochemistry and molecular testing, you need an ideal fixation time which preserves the specimen and the cells, the DNA and the RNA. Okay, so when there is delay in fixation, it will cause autolysis, tissue breakdown. Your assessment of mitotic count becomes difficult if the specimen is poorly fixed. You are not able to see mitosis properly. Then there are a lot of you see retraction artifact that affects your assessment of lymphovascular emboli. Okay, so as I said, fixative is preferably 10 times the volume of specimen, but at least 4 times should be there in a large specimen. You should try to ideally put it in larger buckets, but depending on what you have, minimum 4:1 ratio should be maintained. If you are expecting a delay, then the specimen should be sliced from the posterior aspect. In a mastectomy, slice through from the posterior aspect, preserving the orientation of the specimen. One single slice from the posterior aspect through the tumor, that causes adequate fixation to occur in the tumor if a delay is expected. So this can be done from the surgical side also. They can slice through the, if the delay is expected, that will take time to reach the lab. The specimen can be sliced, so the, and it is has to be uniformly through the posterior aspect so the orientation can be maintained. And you know that if this slice is through the posterior aspect, because in other kind of mastectomies, as I said, the nipple sparing or the skin sparing, you might not have the anterior skin to orient. So if it is uniformly done through the posterior aspect, you will know that this side is the posterior surface of the breast. Now, before you begin grossing, it is very important for you to always have relevant clinical information on hand. If it is there in your histopath requisition form, very good. If not, you should try to obtain some information from lab systems, LIS, DIS. Very important to have that information on hand before you begin the gross, so that you should also know the relevant radiology. What was the mammogram, MRI, USG, what kind of radiology was done, where the location is as per the radiological size, and what is the category of expectation of malignancy that they are expecting from the radiology report. If the previous biopsy has been done, what was the diagnosis, there is a malignancy, what was the biomarker status. Most important, has the patient received any prior therapy, has the patient had any prior surgery, prior excision, prior lumpectomy, or any prior NACT. That information is very important because it affects the way you are going to gross the specimen. Now besides this, what of course the baseline information is what type of specimen you have, what surgery has been done, what type of node removal has been done, and you have to of course check the corresponding list of the specimen you have against the form, that you have all the specimen including what was sampled. If frozen section has been done, has all are those samples also there. Also you have to note any kind of clips, sutures, markers placed in the specimen. If the clinician has placed for some reason, that should be present on the form. So we begin with the basic specimen, that is mastectomy. Now when you receive a mastectomy, when it is a simple mastectomy with axillary clearance, orientation is easy. You have to you can orient it from the axillary tail, which is of course laterally, and if it is not, the axilla has not been included, then the lateral aspect is marked by the surgeon. And the first thing you do is, from the external surface, you palpate the lesion and just feel where the lesion is located. Also, you cross-check the location that where you are feeling the lesion against the radiology. Examine the skin and NAC for any kind of scar, ulceration, puckering, any kind of retraction, inversion, or purdy orange that may be present on the skin. Purdy orange is actually difficult to identify outside the breast, but sometimes it is so obvious that it is you can actually make it out. In the Indian skin, it is not very easy to make out. Then you can have to look for any kind of prior stitch or scar of prior biopsy site. That actually gives you a very good idea of where the tumor is located. And then of course you have to note the dimension of the whole specimen and skin of the breast. This is not for any protocol, but for identification purposes, and the quantum of skin that has been removed. So these are the kind of specimen that sometimes you might be able to see, the specimen with a very obvious inflammatory carcinoma, purdy orange, and hopefully we are not seeing these kind of specimen these days where there is a huge bossulated mass kind of just rupturing through the breast. You also have to note the erosion or ulceration of the nipple, and sometimes the whole nipple can be destroyed. Now how do you start the grossing? You see from the posterior aspect, you can make out the fascia covering the breast. You have to ink this breast fascia or posterior margin. You do not need to ink the axilla because that is not actually a margin. And you can actually, at this point, you can either cut or separate the axilla if you wish. And you have to serially slice in a mastectomy at 1 centimeter intervals from posterior surface. You need a very nice sharp knife to be able to do that. And you have to put cotton swabs dipped in formalin in between the slices, and then place the specimen in adequate volume of fixative so that there is a good fixation, and this cotton swabs will help the formalin to penetrate between the slices very well. And then next day you can either cut through the specimen or keep the specimen intact, but you have to if you cut through the specimen, you have to keep the medial to lateral orientation intact. You have to identify, of course, whatever the lesion you are seeing. You have to identify the quadrant of the tumor, the size, the kind of edges the tumor is having. Is it circumscribed, stellate, pushing, the color and consistency, the borders or distance from the skin, and the various other landmarks such as nipple areola complex and base, and any other additional lesions you can identify in the breast. You have to look at this point. If you can see the prior biopsy or lumpectomy cavity size, you have to identify any kind of the cavitary changes or defect in the overlying skin or a scar, and any residual tumor, and then adjacent breast parenchyma. You also have to give a section of the nipple areola complex. Now nipple areola complex, as I showed you on the microscopic slide, you have to give a very nice longitudinal section through the two parallel cuts through the nipple, so that you are able to get a proper orientation of the ending of the terminal lactiferous ducts on the skin. And you have to also include the base of the nipple as well as little bit of the subcutaneous tissue. And this section should be preferably very smooth, and so that it can be properly embedded and you can get a very nice orientation on the microscopic slide. This kind of section actually maximizes the area and you can see the relation of the underlying ducts with the skin. Yeah. Then you have to do the measurement of the tumor, the specimen. This I already tell, the tumor and any other lesion that you can identify. Now, sometimes the tumor is very easy to identify. You can make out some kind of necrotic, ill-defined, hard mass, and you can see that there is a tumor. And typical fibrocystic changes are also easy to identify, that you can see cystic change with some kind of what looks like a rubbery appearance in between. But it is very difficult. I know most of you will agree with me that this kind of changes are seen many times, and here it is very difficult to identify whether this is an invasive tumor, various nests, or is this a fibrocystic change. So what helps here is palpation. In an upfront specimen, the fibrocystic changes are nearly always rubbery, while if you have a tumor, it is usually different, very hard in consistency. And this was a specimen grossed by my student, and with the help of palpation, they were able to identify this kind of a hard tumor in between what was otherwise typical fibrocystic changes. So palpation is your friend. Do palpate all the slices properly so you are able to identify tumor between, and then you can identify the size and everything once you are able to identify the tumor slice through and look at the morphology and everything compared to fibrocystic changes. Sometimes you can have palpable DCIS, which looks like this kind of a circumscribed nodules. You can see multiple circumscribed nodules filled with yellowish chalky substance which can extrude from the surface. So this kind of comedonecrosis type of DCIS or palpable DCIS can also be identified grossly, but many times it is kind of in the background of an invasive tumor. So besides this, you have to remember that in the gross appearance, most of the time irregular stellate lesions indicate malignant carcinomas, but there are certain exceptions such as fat necrosis, radial scar, microglandular adenosis, sometimes which can show a stellate appearance. And most of the time, well circumscribed lesions will indicate benign lesion like fibroadenoma or even intraductal papilloma or benign phyllodes tumor, but sometimes malignant lesions such as medullary or triple negative carcinoma, intraductal carcinoma, or even a high grade phyllodes can show you, and sarcomas can show you circumscribed margin. So these gross appearances, I'm just showing you various types of gross appearances that you have to note down in the your grossing report. So this is just to show you a circumscribed lesion in which you have slit-like spaces. This is not a mastectomy specimen, but you can clearly see it's an encapsulated lesion. So it is a fibroadenoma with slit-like spaces. While here you have a very large bossylated lesion. It is circumscribed, but it is forming huge mass over the skin also, and it is so fleshy in appearance and there are no slit-like spaces. So this is a sarcoma. So these kind of gross descriptions can help, convey the gross appearance to the person who is seeing the slide. And how do you take the sections of the mastectomy? The largest cross section of one of the slices you will take, and in that the slice that you have selected, you will take the cross section of the tumor, and additionally one section per slice. Additional slices that you have, you can take one section per slice for large tumors. And if the tumor is less than 2 centimeter, you should submit it entirely. You have to take sections with the adjacent breast, so that various other parameters can be noted, and it also serves as control for your biomarkers. The base or the posterior margin you have to take nearly always radially, and try to avoid taking it in a shave manner. I will explain that later. And if the tumor is close to the to any kind of other margin, you can take ink that and take that margin. Overlying skin, scar, nipple areola complex, any other additional identified lesion anywhere, and if you have another lesion anywhere, you have to give the distance between the main tumor and the other additional lesion and intervening parenchyma, and I will tell you how that has to be taken. So again, I'm coming back to my residents. um, Faizan, can you tell me what is the significance of T size measurement? As I said, you have to measure the size of the tumor. Can you tell me the significance? Is Faizan there? If not, Ford, can you tell me?
Hello? Ma'am, it will
Yeah,
help for staging purpose.
staging. So how does it help in staging?
Ma'am, the more the larger the tumor, the stage will be more.
Yeah, so according to the AJCC, there are different cutoffs of T size that we use for
Yes.
staging. And how is that important? The higher the T size, the larger the poorer the prognosis. So it has been seen that certain cutoffs, certain centimeter cutoffs can be used to say that the tumor is likely to recur or likely to metastasize depending on the T size. So that is why for every tumor, basically the most important information you start with is the T size. Now, how do you measure the T size when you are seeing multiple tumors or you are seeing surrounding DCIs? As I showed, you can have palpable DCIs, comedotype. How do you measure the invasive tumor? Can you tell me? For mm, Kasturi, can anybody tell how to measure when there are multiple tumors? Which tumor do you measure the size of? Do you measure
Yes,
all
ma'am.
the tumors? Do you
No, we
measure
measure only the
nothing?
largest largest.
Yeah. So the T size, basically the staging is done as per the largest tumor that you can see grossly. And if you are seeing any additional tumor, you give the size, intervening distance and size of those also. So why it is important, I will show you in subsequent slide. Now, final T size, is it gross or is it microscopic? What you have written in the gross, is that the final T size or is the microscopic T size final? Kasturi.
Gross.
It is the gross size if that is the accurate size. So I will tell you how microscopy can also affect. Now, as I said, you have to take the specimen and you have to take the largest. When you take the section, you have to take the section with the largest diameter of the tumor and try to take it in a kind of a grid form. Matlab ki the whole section, the whole tumor, one slice you are giving, that you are seeing them contiguously. So then this you can see under the microscope and calculate and check whether your gross size is correct or not. So most of the time in the report, your gross size is the correct one, but just if you take the section in properly in a grid manner, you can see whether the gross dimension was correct or not, or if it needs to be altered. So most of the time your gross dimension will go, but sometimes you might need to identify it under the microscope, alter the size under the microscope, and I will tell you how. So as Ford said, the first most important thing that we do is measure the T size, which is the largest dimension of the largest invasive carcinoma to the closest millimeter. And it is used for prognosis and deciding the adjuvant therapy. And the larger the size of the tumor, the higher chances of involved node and metastasis. And what is the T size staging? As per the AJCC, you start with T1, T2, T3 based on the size of the tumor. T1 being less than 2 centimeter or 20 millimeter, and you have to remember this is less than or equal to. This equal to is very important. You can also do the micro metastasis if it T1 micro when it is less than 1 millimeter, or you can do a T1 ABC staging depending on your requirements of your institute. But even if you do T1, T2, T3, that is enough. You can do it is less than 2 centimeter, more than 2 centimeter, but less than or equal to 5 centimeter, and more than 5 centimeters. So microinvasive carcinoma less than 1 mm, but the rest of the this thing is macroscopic carcinoma, and between less than 2, 2 to 5, and more than 5. So these landmarks are important to remember in the breast. Accordingly, or staging is done. And as I said, how do you measure the T size? Now, if you have one large invasive tumor, you can make out on the gross with some surrounding DCIS. You can give the whole tumor size and as per you, what is the largest invasive tumor size. So this can be confirmed on microscopy whether the whole tumor size is the same as the largest tumor size. If you have multiple invasive tumor, the largest invasive tumor is the one that whose size will go in the staging. And accordingly, the patient will be staged. Now, if you have grossly multiple invasive tumor, they are all present very close and you are not able to make out, then again, you have to give the whole tumor size and then you can cross check whether which is the largest invasive tumor size on microscopy. When is a tumor considered multifocal or two different tumors is when there is a distance between them of at least 5 millimeter. They are considered different invasive foci. DCIS is not counted in that. Invasive tumors, if you have, if the distance between them is 5 mm. Now, where did this 5 mm come from? So if you see, if there's in 3 dimensions, there is a tumor which is having, multiple pseudopods extending in different directions, and you happen to take a section like this that I have marked here. If you happen to take a vertical section through this, like in this manner, you on the slide, what you will see is you are going to see the foci of tumor in with a distance between them. But in 3 dimensions, actually, the tumors are connected. So it is taken by convention. It is not under some kind of scientific evidence base, but in by convention across the whole world, it has been taken as by convention that if the tumors are having same histology and they are within 5 millimeters of each other, then it is taken as single tumor. But if they are having distance of more than 5 millimeters, they are considered a separate tumor foci. And you have to sample the intervening parenchyma in between them to check whether there is any microscopic extension of the tumor. You might not be seeing it on the gross, but whether there is any microscopic extension, you have to what if you are seeing 2 tumors as 2 separate lesions, you have to take the distance intervening parenchyma between them to confirm there is no microscopic extent of one tumor to the other. So now I will ask, is Faizan there? Or Swarupini? Swarupini, are you there? Then I'm back to Kasturi. Significance of the other reporting parameters, such as tumor focality. Can you tell me? Why do we need to put the tumor focality as a core parameter in a report? So what does tumor focality mean? Whether the tumor is unifocal or multifocal.
Unifocal or multifocal.
So why do we need to put that in the report?
For lymph node metastasis or for local recurrence.
So more than lymph node metastasis, it is chances of recurrence. If a tumor is multifocal, it is more likely to recur, and the if the tumor is multifocal, accordingly the radiation planning also needs to be bigger. Instead of giving just radiation to the area of the tumor, it has to be a bigger radiation planning, and there are higher chances of recurrence. So that is why tumor focality is important. Now, what about extent of DCIS? Though it is a non-core parameter, what do you mean by extent of DCIS? Can you tell me?
Measurement of the total area which is involved in the DCIS.
So extent of DCIS is basically extensive DCIS, or it is not extensive. So can you tell me what does extensive DCIS mean? When do we call presence of extensive DCIS or extensive intraductal component?
When it involves more than 25% of all the tumor area.
Yes, and
it forms beyond the invasive component.
Yeah, so it is both. It is not just presence of 25% tumor, but it is presence of DCIS around the main tumor also. Not either or, it is both together. And there is one more definition I will tell you. And then what is the significance of having lymphovascular emboli? What
or
is
any axillary metastasis.
Yes. So especially if there is axillary nodal metastasis already there, then okay, if you see or do not see LVI, maybe it's not that important. But if especially the nodes are negative, then presence of lymphovascular emboli indicates that the tumor has spread beyond the primary site. So it is a very important parameter which is taken into account for giving chemotherapy or not. So first I will discuss what is extensive intraductal component. As you said rightly, it is when DCIS comprises more than 25% of the area within the invasive carcinoma, as well as there is DCIS around the invasive carcinoma. And the second definition is when there is small DCI, small invasion, micro invasion associated with extensive DCIs. In between multiple DCIs, you are seeing small foci of invasion or micro invasion. This is also a focus of definition of extensive intraductal carcinoma. And how will you be able to assess them? When you take the tumor sections with the surrounding breast parenchyma, then only you will be able to assess extensive intraductal component. And that is why any section of the tumor you take, it has to be with the surrounding breast parenchyma. to be able to assess the extensive intraductal component. And this the EIC or extensive intraductal component is a crucial factor for recurrence, especially in patients treated with conservative surgery. And as I said, the tumor sections need to be taken with the adjacent breast. Similarly, lymphovascular emboli, when there are carcinoma cells present in the endothelium lined space, which can be lymphatic or blood vessel, this is a significant predictor of local and distant recurrence in node positive and node negative breast carcinoma. And when do you call LVI? This I will just cover, though it is basically a microscopic feature, but it is important. When you have to assess the LVI, it should be present outside the border of the invasive carcinoma, at least 1 millimeter away from the tumor. So again, you need to sample tumor with surrounding breast tissue. Many times I have seen the sections have been taken with just the tumor slice in the whole section. No or hardly any breast tissue in the surrounding surrounding breast tissue in the section. That is not how you're supposed to take tumor. Every section of the tumor should be accompanied by some amount of surrounding normal breast parenchyma. It is important for assessing EIC. It is important for assessing the quantum of DCIs. It is important for assessing lymphovascular invasion, and adjacent normal ducts serve as internal control for assessing biomarkers. Okay, you have to remember that lymphovascular emboli usually do not confirm with the contour of the vascular space. You should be able to see endothelial cell nuclei lining the vascular space, and lymphatics are usually also found adjacent to blood vessels. So if you have small lymphatic that you're thinking is it LVI or not, but you have adjacent small arteriole next to it, you can kind of presume that this is a LVI. So this is just to show you a section of the tumor in which you can see 1 millimeter away from the tumor, you are seeing these multiple linear extensions. So these are not DCIs, these are LVI. They have some kind of space. It is attached to the wall. They are not actually following the contour of the space as nicely. Now here you have, I am not sure you are able to see in the corner, there is a small amount of DCIs here, and these are LVI. So you can compare the difference between the LVI and the DCIs. So that was about LVI. Now the importance of multifocal tumors. As I said that the two tumors are considered distinct if they have more than 0.5 centimeter distance between them. And why is it important? Because it is, as I said, it's required for planning the radiation boost and very effective in reducing local recurrences. Earlier terminology used to be that there is multifocal, multicentric. It should be in different quadrants, and it is multicentric. If they are present in the same quadrant, they are multifocal. But that definition is not much used because, as I said, the quadrants are artifactual. We have created the quadrants. The tumors don't follow the quadrants. So the current dictum is that if there is more than 5 centimeter distance between the tumors and they are distinct tumors, they are considered multicentric. But more often what you have are multifocal tumors, that any tumor more than 5 millimeter away is a multifocal tumor. And how do you submit the intervening parenchyma? Now, if the tumors are very close, then you can kind of take this kind of section in which you are taking a section with both the tumor in the same plane. But it is better that most of the time you take a section which is perpendicular between the two tumors. It is easier when the tumors are more than 1.5 centimeter away, but even if they are like kind of 1 centimeter away, it is strongly recommended that you take a perpendicular section between the two tumors, because this will cover a wider area of wider area of the breast parenchyma between the two tumors, so you can confirm that there is no tumor extending from one side to the other. So how do you do this? You have two different tumors. You have taken the sections in a perpendicular manner between the two tumors, and the intervening is not showing any tumors. Now, how will this be staged? It will be staged as multifocal disease, but the largest T size will be the which is the largest tumor. It will be staged according to that tumor. Now, suppose there is this kind of tumor which is somewhere connected in between in a narrow stalk by two kind of lobulations, and then you take the section through the intervening parenchyma here. So your intervening parenchyma section will show you the tumor. And how will this be staged? Now here the final T size will become the gross size of this tumor, the gross size of this tumor, largest dimension, and the intervening parenchyma, whatever distance you gave between them. So the final T size will become very large. So maximum width of both tumors plus intervening distance become the final stage, and that is why how you have to give the sections. If you give the section properly, you will be able to make out whether it is a large tumor with lobulation or whether it is a multifocal tumor, and the T staging of both the tumors is different. So this is just to show you one case in which the resident very diligently identified that there were 4 tumors, and they gave the distance between them. There are quite big distances. They are 10 centimeter distance. Here it is closer 1.2 centimeter, 5.5. So these distances were given along, making a kind of nice map for me to identify, and we were able to see that the intervening parenchyma given between the tumors, there was a tumor present in the with the similar morphology present in the T1, the largest dimension, T2, T3, and the intervening parenchyma between all these tumors was free. So accordingly, this tumor which was staged as multicentric tumor with the dimension of the largest tumor as the PT size. While in another case, there were 2 tumors identified, one 3.5, one 1.4, with an intervening almost 3 centimeter distance. But here the intervening parenchyma was also showing tumor. So now the total T size became, instead of 3.5 centimeter PT2, the total T size became 7.7 PT3 in the resection. So you see how the importance of the intervening parenchyma, and if you give it in a perpendicular manner, you will be able to see the extension, if there is any, between the 2 grossly identified tumors. So here your microscopic T size will become the final T size, that you will have to add up the gross dimensions as well as add up the intervening parenchyma. So, okay, now the next staging parameter that we give in the report is the tumor extent. So, can anybody tell me what does tumor extent mean? I'm not sure who is there. Divyashri? So what do you mean by tumor extent? Extent of tumor.
So it involves the skin.
So extension is to either the skin, nipple areola, or the underlying chest wall. These alter the management. Okay. So can you tell me how do you define chest wall or skin involvement? So if the tumor is involving dermis of the overlying skin or nipple, is it skin involvement?
No, ma'am. Only if there is ulceration of satellite skin lesions, then it is
Perfect.
skin involvement.
Perfect. And if the tumor involves the pectoralis major muscle, is that chest wall involvement?
No, ma'am. Yes,
And
it
so
should involve the
when
chest
does
wall
when is the chest wall involvement considered?
intercostal muscle involvement can be considered.
Yeah, if the ribs or intercostal muscles are involved, then it is chest wall involvement. And what if the tumor extends into the epidermis without ulceration?
It is not skin involvement.
Not skin involvement. Very good. So this is the AJCC diagram for the extent of tumor. You have to remember that if the tumor of any size is involving the chest wall or skin, with ulceration or ipsilateral macroscopic distinct nodules separate away from the tumor, then it is considered a PT4. And in that you have PT4A, that is chest wall invasion of pectoralis muscle or adherence is not enough to call invasion of chest wall. You have to go to the underlying structure, the ribs, intercostal muscle or the serratus anterior muscle. And only involvement of pectoral muscle without chest wall structure does not constitute chest wall invasion. So this is an important distinction to remember, but we do need to mention whether the underlying skeletal muscle is invaded or not. It does not change the T stage, but it is required to mention the underlying muscle involvement because it changes the radiation planning, and it might require the resection of the underlying pectoral muscle in a second stage surgery. Besides its PT4B, this I'm asked many times, that if the skin is involved, if the dermis is involved, do we call it PT4B? No. Only ulceration of the skin by the underlying tumor, or if there are separate ipsilateral macroscopic satellite nodules, or if there is edema of the skin which is not meeting the criteria of inflammatory carcinoma, that is, it is less than 1/3 of the skin of the breast. This becomes a more of a clinical definition that you might not be able to give on the gross and microscopy, but ipsilateral macroscopic satellite nodules or ulceration form PT4B. And dermis only or epidermis without ulceration or presence of Paget's disease does not make it PT4B. So these are the definitions. Underlying chest wall is deep invasion, skin ulceration, or a separate satellite nodule. So these definitions are important for us to remember. Sometimes in T4C you can have both. Now this chest wall invasion also is more of a radiological finding. Here you might see a radical mastectomy in which even the base of your excision in the radical mastectomy is also involved. But most of the time you can also get a specimen of the underlying ribs and intercostal muscle if this kind of involvement of chest wall is there. Now, the additional specimens that I said that you can sometimes see these days are the skin sparing mastectomy. Now, here you have to remember that in the main mastectomy, you had only one margin, that was the base. And sometimes, if required, the skin margin, if there is any kind of ulceration and it is near the edge of the skin, you can take. Otherwise, there is no skin margin in a complete simple mastectomy or radical mastectomy. But in this case, here you are going to have additional margins besides the base. You for the skin sparing mastectomies, you kind of make a kind of horizontal line which extends through the nipple towards the axilla, and this way you divide the superior and inferior halves of the specimen. If you have facility, you can color them differently, and according to where the tumor is located, you have to give a section of the tumor with the superior the soft tissue margin or the inferior soft tissue margin besides the base. So there are two additional margins of the soft tissue in a skin sparing mastectomy, and in a nipple sparing mastectomy there is an additional margin. Instead of the beside the superior inferior, you also have to give a margin of the there is a stitch mark to where the nipple was located. Either it is inked or a stitch is marked by the surgeon. That area has to be sampled well, because if there is any kind of in situ or invasive tumor here, that means the patient needs to have a revision of the skin and the nipple needs to be excised. So in our hospital, generally this area is separately sent as an NAC undershave, and it is examined in frozen. But if it is not done, frozen is not done, and you have a nipple sparing mastectomy, you have to take a section through where the nipple was located and confirm that there is no residual or invasive or in situ tumor there. Now, completion mastectomy, it is a very most common specimen that I have seen that kind of gets grossed inaccurately. So I will like to tell what are the different types of completion mastectomies you can get. Now, it can be that you have received a completion mastectomy in a same sitting as the wide excision that has been going on, or a breast conservative surgery going on. So you can have in the same sitting that a lumpectomy has been done, and for close margins or margins positive in frozen, they decided to go ahead and do a mastectomy. So this is a completion specimen done at the same time. You are going to have a defect. There is no attempt at suturing, of course. You are going to have a defect of the lumpectomy site present in the specimen that you received of a mastectomy. And here there is no suture, no scar, no this thing, a lumpectomy defect. And where do you have to sample? You will have to sample whichever margin was reported positive. Around that, definitely you need to sample and check whether there is any residual tumor. Besides that, the grossing will be as per the any other mastectomy. Now, this is another specimen in which a surgery was done prior, and there is maybe a lumpectomy or a wide excision, and there is an old heel scar, and the specimen has been excised for a suspected recurrence. So here you have to again check the history and see if there were any margins reported positive or close, and the recurrence of the tumor is most likely going to be somewhere below this scar lesion, or in addition there sometimes might be a recurrence somewhere else in the breast. So you have to look for not only presence of any lesion below the scar, but also if there in the rest of the breast there is any additional lesion, and if there is, you have to again give a distance from the main initial lumpectomy site. And sometimes you can have a large recurrence in which of course there is no problem where the tumor is, and it is very the specimen becomes basically just a confirmation that there is a malignancy and the margin of the skin and the base. So when you have had a prior surgery done and the old heel scar is there, what will it look like? On the slice that you take, you are going to have some kind of fibrotic area with an ill-defined yellowish white appearance. This is basically the prior lumpectomy site. And where do you have to sample? You have to sample, of course, this whole lumpectomy site completely, taking into account that some amount of surrounding breast parenchyma. You have to see the margins of the prior excision cavity, and you have to sample the overlying skin. Todd, can you, Kasturi, can you mute yourself? Yeah. Then sometimes you can have a cavity, you can clear, sometimes the cavity might be obscured, but sometimes you can clearly see a prior existing cavity also, and you have to take the gross section, keeping in mind the cavity walls and the overlying skin. And how much do you have to sample in a completion specimen? The sections you have to take is 2 times the largest dimension of the cavity. Whatever cavity or the size of the lesion, the ill-defined lesion you can see, you have to take 2 times the largest dimension. So if a cavity is 5 centimeter, you have to take minimum 10 sections. If it is 2 centimeter, minimum 4 sections. And if no cavity seen, check the location of the lumpectomy and take sections around that area. So next we come to wide excision. So yeah, Ford, are you there? Can you tell me why do we do a BCS instead of a mastectomy? Is Ria there? I think the student Divyashri, it's back to you. Why do we
Ma'am,
do a BCS?
for cosmetic purpose, ma'am.
So yes, so mastectomy are very, very disfiguring surgeries, and it is considered these days that if a tumor is small and it is unifocal and it is easily excisable, it is an operable tumor, then why subject the patient to the extensive surgery which is disfiguring, and go for, instead of that, if we can take a smaller amount and do cosmesis, then the patient can have a normal life. So there are certain indications why it is not done, like when there is a huge multifocal tumor or extensive skin involvement. In such cases, surgically mastectomy is preferred. But as far as possible, the move of the surgeons these days is going towards a BCS rather than a mastectomy. The patient also these days, the treatment is so good that the patient lives for years. So it is important for the patient to have a good, normal, healthy life. So for that reason, BCS is being preferred surgery. How is this different from the mastectomy? Ford, can you tell me how is a wide excision different from mastectomy? In the grossing or in the reporting, what is the major difference?
Ma'am, mastectomy is removing the entire breast, and wide liposuction is removing the
So what
healthy
is the
tissues.
major difference in your reporting and grossing?
Ma'am, pardon?
What would be the major difference in your reporting or grossing between mastectomy and a wide excision?
Ma'am, margins.
Yes. So here, instead of having a one single margin of the base, you are going to have multiple margins, which are in which your reporting and grossing has to be different from what you are not going to have your skin NAC in a nicely oriented manner the way you have in a mastectomy. Your orientation is going to be dependent on a surgeon. It is not going to be that you see the specimen and you will be able to orient the way you are able to do for a mastectomy. So you need proper orientation so you are able to give the margins properly, and that is the most important reporting parameter in a conservative surgery. And why do we do? The aim is to reduce the tumor burden while maintaining the appearance, and what is called a positive margin is tumor on the ink. Now in a mastectomy, in a wide excision, if we start sampling all of the surface around a sphere, we are going to need a huge number of sections, right? So how do we take the margins in a breast conservative surgery, and how do we assess them? We imagine the specimen, instead of like a sphere, we imagine it like a cube. In fact, our surgeons have become so used to this, they kind of, instead of taking out a ball of tissue, they generally make it slightly cuboid or cube shape. So we imagine the specimen of wide excision like a cube with the tumor at the center, and we take sections, 6 sections that are representative of the closest area from the tumor to the nearest margin that you can see like this, and we give this kind of what is known as a radial section. So we can see the tumor and the margin preferably in the same section, and we can not just see if it is free or not, we can also measure the distance between them. So instead of imagining a wide excision like a sphere, we take it like a cube and give 6. You will have 6 surfaces with this kind of superior, inferior, medial, lateral, anterior, and posterior. So 6 surfaces you have to sample and 6 margins. And how do you do the orientation? You need 3 directions from the surgeon. So most of the time, the anterior, you will have a small little sliver of skin to mark that this is the anterior surface. But besides this, you need at least 2 more to be able to orient it properly. You need a short suture, which is usually superior, and a long suture lateral, which is general dictum followed by most surgeon. So you are able to, even if it is not written on the form, if it is the general dictum in your hospital, you know that this is lateral, this is superior, and this is anterior. But if it is not clear, before cutting the specimen, please call the surgeon and immediately confirm the margins before going ahead. So once you have properly identified in this way that this is the orientation of the specimen, you go ahead with inking. So if the specimen is large, then you can color the whole specimen outside with black ink and give all the margins in separate sections. But if the specimen is small, and usually wide action specimens are relatively on the smaller side, then it is better if you do differential inking, because you are going to have multiple margins in the same section when you slice through. So if you are able to do, you should prefer to do differential inking for small specimen. And in that, you can use some kind of, you can use a conventional dictum in your hospital that, base is black, or, anterior is this, lateral is this. But if whatever type of orientation you use and the ink you choose, you have to definitely mention it on the form, because you will also, forget after 2 days when the slide gets ready, which side I colored what. So please do mention it on the form, whatever color code you have used. You have to ink externally in all directions to identify the surface which has been cut by surgeon. As I said, the positive margin is tumor on ink, not, you of course many times you will be able to see cautery also, but the ink, if it is there nicely placed and you see a tumor touching the ink, that is very, confirmatory on the microscopy that the margin is involved. What kind of inks you can use? You can use acrylic paints. These are very easily available in India these days. India ink, of course, is used everywhere, and there are lots of other more expensive inks, but most of the places the acrylic and India ink are used, and there are various pros and cons of the inks you can read. And it is important that you dry the surface completely, then apply the ink, and you can fix it using 10% acetic acid or Bowen solution, and avoid seepage. Do not kind of, slap it on. You have to dab the ink and avoid seepage, because the fat lobules, they will have lot of ill-defined margins. It is not a proper fascia somewhere in between. So the ink is going to seep in inside, deep inside the fat, if you do, do a very, hand heavy job. Then there also, if where one margin is ending, where the other is beginning, if it is a kind of not a cuboidal but more of a rounded specimen, then you might have some amount of guesstimate. But if it is a cuboidal specimen, it is easy to identify, like in this specimen, which side is which margin. You are able to identify easier. And how do a sample? As I said, so now when the tumor is, less than 1 centimeter from the margin, a radial margin is definitely very good, because it will give you the proper orientation between the tumor. You can measure the distance as well as clearly see if the tumor is approaching the ink. And if the margins, if the tumor is more than 1.5 to 2 centimeter away, and even for medial and lateral sections, most of the time the shave margin is given. In the shave margin, what is the difference between a radial margin and a shave margin is that in a shave margin, if any kind of tumor is present, it will be considered a positive margin. While in a radial margin, the tumor is present, but you have to measure the distance from the margin. So that is why it is very important for you to know whether the margin that you are seeing on the slide, is it a shave margin or is it a radial margin? Because tumor will be present in both. One margin will be considered negative if it is away from the ink, while this margin, if there is a tumor, it will be considered positive. So whatever type of margin you have to have given, you have to mention it on your form that this particular margin I have given shave, this particular margin I have given radial, because interpretation on microscopy will differ, and your accordingly your report will differ completely. You can also make
Excuse me, ma'am.
Yeah.
I'm sorry to disturb. Ma'am, I had a query.
Yeah, go ahead.
Ma'am, can we take both the things, like if in the same specimen, can we do the shave margin as well as radial margin, like according to the
Yeah.
size of the tumor, or
Yeah.
yes, ma'am.
So as I said, if the tumor is very far away and you clear cut that there is nothing in between, you are sure that there is no kind of any extension of the tumor microscopically or any other lesion, interesting lesion of choice, which you would like to see on the microscope on the radial section. If you are clear cut that it is a very far away from the margins, then you can give a shave margin. But in a smaller specimen in BCS, it is preferable to give a radial margin. One margin can be radial, other margin can be shaved depending on the distance of the tumor from the margin and the size of the tumor. Now you can also convert this shave margin into a radial margin like this. So if you have a shave margin, you have taken a shave margin and it is inked on one side, you can slice it like this and give, multiple sections of that, tiny sections like this into the same block. So this radial can also get converted into a shave. This shave can also get converted into a radial, that whichever one of the bits is showing the tumor, you will be able to see a distance from the ink. So that is also possible. This is something we do for our medial and lateral margins regularly. When we are if it is closer, then we kind of, if we have, because medial and lateral end up getting becoming shaved margins because we slice the tumor from medial to lateral side. So in these sections, we can kind of make a radial margin out of a shave margin also. Okay, I hope this is clear.
Yes, ma'am. Yes, ma'am. Thank you, ma'am.
So this is just a specimen to show you that, see, in this specimen, you can make out the distances on the gross, and this specimen, this side, you could still get away with giving a shave margin. But these other, both these side, definitely need to be given as radial margins. So you can measure the distance on the microscopy, and the microscopic distance might be different from the gross distance. Here, you might be seeing the tumor stopping here, but microscopically, a band of tumor could be extending to the ink also. So that is why it is very important to give these margins as, when it is close, it is important to give it as radial margin. So here you can see in this particular area, this section has been taken and you can see that the tumor is extending to here. Now here little bit of cautery is there, but more important, the ink is this side. So the distance of the tumor from the ink can be measured. This particular section taken here, you can see that how close the tumor is to the margin, but actually not a positive. Here in gross, you might be confused that it looks like it is almost approaching and it's involving the margin. But here you can measure the distance, that it is not a positive margin, it is a negative margin. However, it is close. It is 1 millimeter away. Okay, so your report can carry all this relevant information if you have given the margin accordingly in a radial manner. So how do you do the grossing of the wide excision? You again measure the size and of the tumor and everything, the landmarks. There are besides the skin, there is no other landmark, basically distances for the margin. And then you give the sections. How do you give that? Again, you have to identify the area, the slice with the largest dimension of the tumor, and you have to give that along with the, if you are having multiple margins in the same section, you have to have different color of the margins. If you do not have different inks, then you have to give each tumor section separately with the margin. You cannot give multiple margins in the same section if there is no differential inking. So if you have only black ink, be careful that each margin has to be given separately with the tumor in a radial manner, and each margin has to be labeled differently. No, you cannot have multiple margin, 2 margin, 3 margin in the same section if they are all colored black. Okay. So it will not be possible to orient it even with any kind of diagram that which margin was which. Now this is the end that I'm trying to show, that this kind of a lateral slice. Now this was actually a shaved margin at the end, and it has been given in, it has been sliced up into 3. So it has been converted into a radial margin. So a shaved margin also can be converted into a radial margin, and you can have ink on the outer surface to tell you how far it is. So this is the section. You can see that this is the shaved margin and it can be sliced up and given in a radial manner. Okay, and each margin has to, you have to remove all the other kind of threads and everything at this point. They have to be removed because they damage our blades. So, and you also have to make a diagram of the kind of tumor sections with the whatever margin that you are seeing on the gross, how close they are. It would be better if you make a diagram and give the tumor in a grid manner with the surrounding parenchyma, as I said, and mark the distance of in which section you have given what margin, so that it can be correlated on the microscopy. Okay. So now the significance of margin, of course, they are predictors of local recurrence. So if there is margin involvement, it requires either re-excision or a decision on radiation or chemoradiation. And positive margin, any tumor in the ink surface, either gross or microscopic. Okay. And when do you mention close margin? When it is within 5 millimeter, it has to be documented. It is not a positive margin, but it may impact the surgeon's or the clinician decision that whether they want to undergo a revision or a follow-up mastectomy. But it is not a positive margin. You do have to document it that it is close. And for DCIS, 2 millimeter is considered as adequate margin. And why? Because in DCIs you can have skip involvement. So just the absence of DCIs at the margin or at the ink does not mean that there is no DCIs elsewhere. So that is why 2 millimeter is considered the adequate margin for DCIs. And you can have errors in margin documentation in the gross, because the weight of the specimen, it can cause the tumor to the specimen to flatten and lose the height, and you might even also lose orientation from OT to the grossing table. So as I said, if you're not clear before cutting the specimen, do call the surgeon and get them to orient it properly before you go ahead with grossing, because this is the most important reporting parameter in a BCS, and once it is lost in the beginning, it is not possible to orient the specimen in a subsequent data once it has been cut up. Okay, neither will the surgeon be able to do it later, nor will you be able to do it later. Now, another another non-core feature that can be included in the reporting is whether the involvement of the margin is unifocal or it is multifocal or extensive. And there are some definitions given in the ICCR dataset at what is unifocal, multifocal. You can go through that, but it is basically whether just the tumor is just about reaching the margin, is it unifocal, or there are multiple foci, or it is like along a wide distance more than 5 mm the tumor is involving the margin. So these are additional parameters that are non-core but can be added to the report. So I am back to Ford. You are there, Ford? So in these images 1 and 2, which of these images is showing a positive margin? Any of you can answer. Image 1, image 2, both or none? So
Image 1 is showing positive.
One. Ma'am, image
Yeah.
one.
One.
And image 1.
yes. So is image 2 a close margin?
Yes, it's a close margin, but not positive.
Very good. So yes, image 1 is the correct answer, that you have tumor at the ink, but image 2 is not a close margin. Why? These are lymphovascular emboli. Okay, so lymphovascular emboli present at or near the margin do not make a close margin. They just make a parameter that yes, lymphovascular emboli are present, and you have to be sure that what you are seeing as a tumor, whether it is if it is a lymphovascular embolus at or even near the margin, it does not make a close margin, because the tumor has already gone away from the primary mass. Okay, so this is not what the margin involvement means. If the tumor is directly involving or the tumor directly is extending close to the margin, that is the invasive tumor is the distance of the margin. Lymphovascular emboli are not counted as close margins. Okay, so now regional lymph node assessment. So can anybody tell me how many nodes are considered adequate in a axillary sampling, axillary dissection?
12 to 20.
12.
Minimum 13 should be there.
So actually the basic minimum is considered 10, but the more the merrier. So minimum you can get away with is 10, but if it is a properly grossed axilla, you are going to have minimum 15 nodes there. So do the axillary grossing properly. If it is a properly surgically excised axilla, you are going to have a lot of nodes. So that is only in post-chemo status that you might not get that many nodes, because they become shrunken. But in a properly good size axillary clearance, there are generally 15 nodes, but minimum of 10 is considered sufficient. Now, do we trim the perinodal fat and process only the lymph node? When we have identified the lymph node in the specimen, do we trim away the fat and process the lymph node?
No, ma'am, we take the fat along with it so
Why?
that we don't miss. Ma'am, so that we don't miss any node in between.
No. The
Maybe it
answer
can
is
be
correct, but the reason is wrong.
invasion will be there. Invasion
Sorry?
might be there. In the penal, there might be invasion.
So perinodal extension.
Yes, ma'am.
Okay.
There might be invasion.
Yes, so perinodal extension. So to document perinodal extension, we should never trim away the perinodal fat. Somebody I think just asked what is the ideal number for post NACT nodes. So there is no separate adequacy criteria for post NACT nodes. The adequacy criteria is still 10. But it is accepted that you might not get sometimes you might not reach adequacy if the axillary nodes have shrunken, and in that case you have to document, you have to gross more of the axillary fat to document there are no more nodes, and you have to document the fact that the axillary fat was extensively sampled and only this many nodes were identified. But it is after you have sampled an adequate amount of the axilla that you can say that only this many nodes were identified. Okay, so in a post-chemo setting and the upfront setting, the minimum adequacy criteria has actually not changed, but you have to document. If you're not finding the nodes, it is more difficult in a post-chemo setting. So you have to document that you did sample the axillary fat extensively. So regional lymph nodes, it is the single most important prognostic factor. As we all know, in our MCQs always it is asked which is the most important prognostic factor. It is the involvement of the regional lymph nodes. It is the first station for metastasis, and the presence of the largest size of metastasis more than 10 mm predicts the risk for non-sentinel lymph node involvement. So that is why the importance of mentioning the largest size of metastasis in our reports, and presence of extranodal extension is more than 2 mm is associated with N2 disease, hence predicts higher number of positive nodes, hence the importance of mentioning extranodal extension in our reports. Now what kind of nodes we can get? We can get sentinel lymph nodes which can be intraoperatively or preoperatively. There is a dye or tracer used to identify the first draining lymph node. And then you can have low axillary sampling in which the level 1 fat below the surgically the below the intercostobrachial, the second intercostobrachial level, the nodes that is fat that is sampled below there, that is sent as low axillary sampling. That is considered an adequate replacement for sentinel nodes because it is it is also most of the time containing the sentinel node. It does not need any intraoperative expensive dye or labeling, hence it is more cost effective. So in our country, a lot of time low axillary sampling of a level 1 fat is done instead of a complete clearance of the axilla to identify basically as a substitute for sentinel lymph node. Then you can have the lymph node dissection or axillary clearance. Sometimes you can have internal mammary nodes and other nodes sent along with. So how do you do the grossing? As I said, you separate the axillary fat. If you have a mastectomy, you separate the axillary fat at the time of slicing the breast. You serially slice the axillary tissue medial to lateral. Again, you can put cotton and fix it. Dissect the nodes and record the number of nodes submitted per block. And you have to have, as I said, minimum 10 number of nodes. Maximum there is node. If you get good number of nodes, that is good. And if you are not identifying enough node, you have to submit as much fat as possible. And how do you do the slicing of the nodes? You have to slice it at 2 millimeter intervals. Why is the distance 2 millimeter? Can anybody tell me why do you have to slice at 2 millimeter intervals and submit one node per block? Anybody? Why do we slice at 2 millimeter intervals? So basically the size of metastasis, if it is the difference between a micrometastasis and macrometastasis is 2 millimeter. So if it is less than 2 mm, it is a micrometastasis. If it is more, it is a macrometastasis. So that is why, so that we do not miss micrometastasis, the nodes are sliced at 2 millimeter intervals. You have to include the perinodal fat to document extranodal extension. If there is the lymph node is small, you bisect and submit the entire node. It is less than 5 mm. And in a grossly positive node, it's a large grossly positive node, one section full face through the metastasis. The gross size of metastasis has to be documented, and you have to give the section where you suspect there might be extension into the fat or extranodal invasion. So in a large, nodal mass, when you get 3, 4, 5 centimeter, you are not required to give 5, 10 sections through the 5 centimeter nodal mass. One good section taken preferably through the area where there is extranodal extension is enough to document, and your gross nodal size, the metastasis size, will be the gross size that you have given, whatever 3 centimeter, 5 centimeter. So this is basically the lymph node is a core data set. You have to give the number of lymph nodes you have examined, the number of lymph node in metastatic carcinoma, and the presence or absence of extranodal extension in your report. And again, size of metastasis. What do you consider as the size of metastasis? As per AJCC, the largest contiguous focus of tumor is considered as the size of metastasis, when it is, whether it is present within the node completely, or it is present half inside, half outside the node. This is the largest size of metastasis. Or even if it is present outside the completely outside a lymph node present in the fat, what in other sites is sometimes called soft tissue deposit. In the breast, if it is more than 3 mm, it is considered as part of a lymph node with extranodal extension, so it is counted in the lymph node. Sometimes you can have a complete node with tiny deposits all across. In that case, you can take the size of the node as the size of the metastatic carcinoma. So you have to remember the definitions, which is macro, which is micro, and what are isolated tumor cells. Now, this is important in the upfront setting because they are staged differently. ITCs are basically N0, but N0 ITC, and micromet is MI. But in a post NACT setting, ITC are also counted as positive nodes, and micrometastasis and macrometastasis are staged the same way. So it is important in the post NACT setting that these distinctions do not matter. But in the upfront setting, you will have to give like how many nodes are showing macro, how many nodes are showing micrometastasis. Okay. So now we come to the post-chemotherapy assessment, and I'm back to you, Ford. Why is the post-chemo assessment different, and how is it different? Anybody else? Anybody would like to comment?
It decreases size.
Hmm.
TNF size
Anything
will
else?
decrease. It affects the TNF sizing before surgery, decrease the size.
What if the tumor has not responded and the size is not different? How is basically the grossing in a post-chemo breast different from grossing in a upfront specimen? Can you think? The way you said that BCS may important is that we have to give the margin. So that is the major difference between a BCS and a mastectomy, that you have to report on a number of margins. Here, what is the difference? You can have post-chemo mastectomy, you can have post-chemo BCS. But what is the major difference in a BCS compared to a post-chemo breast compared to an upfront breast? So the major difference is that whereas in the upfront specimen, the tumor is very easy to identify, here in a post-chemo specimen, the tumor or the tumor bed is very, very difficult to identify. The more a tumor responds to the chemo, the harder the job of the pathologist to identify where the tumor is and what is the T size. So your gross T size, your gross distances, your gross distance from margins and the various other landmarks are not as sacrosanct the way they are in an upfront specimen. So there is a lot of coordination required between the gross and the microscopy in a post-chemo specimen to be able to give an accurately staged report. Okay, so it is quite different. You have to gross it and think it and look at it in a different way as compared to both the specimen that I have shown till now. So in who do we give the neoadjuvant chemotherapy to? So most of the time, the neoadjuvant chemotherapy is being given to locally advanced breast cancer or large operable breast cancer to make the tumor easier to operate, to shrink the vascular supply, and the tumor, what was very huge earlier, becomes smaller in size and less vascular. So it is easier to operate for the surgeon, and they can convert even a mastectomy into a BCS if it shrinks adequately. Recently, even for early stage high risk breast cancer, like even T1 T2 but TNBC, so even in those cases these days neoadjuvant chemotherapy is increasingly being given, and the utility, as I said, it improves the operability, downsizes the tumor, and importantly, response is an excellent predictor of outcome, that if there's good response, the outcome is better. And it is considered in certain stages, it is considered that you can measure, basically it can give you an assessment of how sensitive the tumor is to chemotherapy. So you can measure that. by measuring the extent of response, you can say how sensitive the tumor is to the drug being given. Poor response provides opportunity for changing the chemotherapy or supplementary chemotherapy. And if you have a complete pathological response, it is accepted as criteria for approval of new drugs in trial settings. So for these reasons, it is very necessary for us to document the extent of pathological response. So this way, this is an additional parameter that we do not need to give in the upfront setting, that not only do we have to identify the tumor, we also, or stage the tumor, we also have to give the response, that how well the tumor has responded to chemotherapy, that has to be incorporated in the report. So that is for these reasons, the assessment of post NECT tumor is quite different. Now, here the role of the pathologist is to determine the residual tumor size and assess response, distinguish treatment effect of the benign breast from tumor, detect nodal metastasis in the presence of treatment effect. As I said, the nodes become very difficult to identify and assess microscopically also in the presence of tumor, and evaluate margin status for occult single tumor cells, because what you see grossly might not, the distances might be quite different in a microscopic level when you see the margins. So the role of the pathologist are many, but the challenges are also many, because once you give the chemotherapy, the tumor becomes soft, less well defined, it becomes low in cellularity, it becomes heterogeneous. So you are, that palpation that I showed in the upfront specimen, that does not work well here, because the tumor bed becomes softer. So tumor bed is difficult to identify, difficult to measure. The axillary nodes are softer, atrophic, more difficult to palpate. There is lesser yield, and the assessment of response is variable. If the specimen is not uniformly handled in different labs, if you do not follow stringent guidelines, then it is very difficult to assess the response if your initial grossing is not correct. Reporting parameters also vary across centers. Some centers want, I want this parameter reported in post chemo report, some say another thing. So to make a standardized uniform format, the Breast International Group, North American Breast Cancer Group, big NABCG is a group that aim to produce standardized guideline for evaluation and reporting of the post NACT specimen. And they defined that pathological complete response is defined as no invasive disease in the breast, which is considered as YPT0 or YP in situ, T in situ. If there is no node disease in the sample lymph node N0, then it is considered as pathological complete remission as per the big NABCG. So this is the way the big NABCG has tried to make it easier for pathologists to assess. They have given very nice guidelines. I would ask you to go through them, that how to assess the post chemo specimen. Now here, what the features that I was saying, how are they different in the upfront versus the post chemo setting? Now you can have sometimes grossly apparent when the tumor responds very well to the chemotherapy, you can have complete response. In that case, your specimen is not going to show you anything, or show you little bit small fibrotic scar, which is difficult to distinguish from fibrocystic changes. So microscopically you can just see little bit of fibrosis or inflammation. So unless that it has been marked for you, like with the tumor pre-treatment, there is a in the bed there is some kind of a clip or a marker placed, then in the gross it is very difficult for you to identify where the tumor bed is. So you need to really correlate well with the pre-chemo findings of the mammography, radiography, and the clinical findings to identify where in your specimen you are going to have the residual tumor bed. And the post-chemo mammography, what does it show? That how much did the tumor respond? Did the tumor size shrink? So initial size was 5 centimeter, but the mammo now says 1 centimeter. So what you are seeing as a 5 centimeter ill-defined lesion might just be fibrocystic changes, and you need to look for the smaller size of the lesion. So accordingly, you have to do a very nice correlation with the radiology to identify tumor bed when there is a grossly apparent complete response. Now, sometimes you can have what is known as a concentric response, that the tumor bed remains the same, but the tumor shrinks concentrically. So in this case, for example, here you can see that this was the original tumor bed, but the tumor has shrunk considerably. So you are seeing some kind of a hard, small tumor surrounded by an area of fibrosis. And this is what it would look like in a microscopy. So this is comparatively still easier to identify and gross. that you are having some kind of a small, what looks like a necrotic tumor surrounded by fibrosis. This way, and it would, match with the general pre-treatment T size, it would match little bit and you will be able to identify. But what is very difficult to identify when there is a partial response, or what is known as a buckshot response, when there is a heterogeneous response, that you are having scattered foci of residual tumors scattered all across the tumor bed. Some of the foci might be bigger, some might be smaller, and there is a very heterogeneous cellularity in such case. Then the tumor bed is going to be completely ill defined, and again you have to rely on radiology to identify the tumor bed. So there are multiple response assessment systems that are described in literature, but most commonly used, at least in our country, is the AJCC and the RCB. So AJCC is basically no different. The TNM staging parameters are by and large the same. You just have to add a prefix of YP to indicate that this is a post-chemo assessment. But in an RCB, you have to assess various parameters, like what is the tumor bed area that you have identified. This can be gross or microscopic. The overall cancer cellularity, this has to be a microscopic parameter. Percentage of cancer that is in situ disease, the number of positive lymph node, and the largest lymph node metastatic deposit. So all these parameters, you have to feed it into a calculator that is available freely online. And if you feed it in, you get what is known as RCB class. It calculates, it kind of translates to roughly complete response versus minimal disease, moderate disease, extensive disease. And these, if you can see the graphs here, these different RCB class has shown different very good correlation with the prognosis and outcome. So that is why this kind of effort is made to give maximum information by which the RCB class can be calculated, and accordingly it can be added in your report. Now the AJCC and RCB system are by and large similar when there is a concentric response. So AJCC wants you to measure the largest contiguous focus. Now even in the lymph node as well as in the primary tumor bed, your AJCC and RCB will have the same T size in a concentric response. But when the response is heterogeneous, your AJCC size might be very small, while the RCB size, basically the size of the tumor bed in which you are having scattered response, it is going to be different. Same for the node. So what do? Do you give one? Do you give the other? Most of the time we try to give both. We say the largest contiguous focus measures this one, this much, and the total tumor bed size is this much, and accordingly we calculate the RCB from the total tumor bed size. Okay. So you try to give at least information in your report that should cover both the system, and depending on the the treatment protocols at your hospital, either one can be taken for treatment. And how much to sample? Now, as per the big NSBCG, you do what is known as systematic sampling. This saves time, blocks, and it accounts for heterogeneity. If you have a small specimen, then it can be submitted entirely when that is less than 5 centimeter in size. You can submit the specimen entirely, because that way you can completely be sure that there is no residual tumor. But if what is the otherwise, the recommended is that you have to give 1 or 2 tissue blocks, preferably 2, per centimeter of the pre-treatment tumor size. You have to remember that this is as per the pre-treatment tumor size. Why? Because in the pre-treatment tumor size only, if there is a buckshot response, you will be able to assess the presence of residual tumor. If you go by the post-treatment tumor size, you are going to miss the presence of tumor beyond the grossly identified tumor bed. I will show you this in a diagram. For large tumor, you need to give 5 representative blocks of a cross section. And if there is a large residual viable, when there is a large residual viable tumor, 5 representative blocks are considered okay. And maximum you have to give is up to 25 blocks. Additional sampling may be needed if your microscopic finding do not match the gross size or impression. And as I said, lymph node sampling is by and large same as the upfront surgery, but you have to make if adequate number of lymph nodes are not sampled, you have to go back and sample more. Here I would like to mention that how does your pre-treatment biopsy report of biomarkers affects your grossing. Now, if you have a tumor that is hormone receptor positive versus a tumor that is HER2 positive versus a tumor that is triple negative. So maximum response, it has been seen that PCR rates are highest in HER2 positive tumors, followed by the triple negative tumors. So because these tumors are more mitotically active, they are going to respond to chemotherapy better. And then in these cases, if the tumor is HER2 positive or triple negative, you expect that you are going to have difficulty in identifying the tumor bed properly, and you must correlate well with the pre-treatment location of the tumor. In a hormone positive tumor, on the other hand, the rates of pathological complete remission are very less. So you are going to have a grossly identifiable tumor, but again it can be a heterogeneous buckshot type of response. So you are not going to have difficulty in identifying, but the sampling has to be again proper to identify as per the pre-treatment tumor size. So that is why it is important for you to know the biomarker status before you start sampling. And how do you do the grossing? You see the grossly identified tumor bed, give the largest dimension and submit the largest cross section of the whole tumor bed. Now here in this diagram, they have not sampled the additional surrounding tissue. I would definitely recommend that this area also has to be sampled. And then accordingly, when the sections are taken in a grid diagram, you have to label what area you have given where, and you have to measure the cellularity of the tumor in each section separately. That is the amount of tumor, not the invasive tumor. The amount of tumor including DCIs, the cellularity has to be assessed and then divided by the number of sections to get an overall cellularity. Besides this, you also have to mention the percentage of in situ tumor in each section, and accordingly arrive at a percentage of in situ carcinoma and invasive and the total tumor which you have to feed for the RCB. Now here, so this you can see that in this slice in a mastectomy, in a post chemo setting, this is the tumor that was grossly identified. A small hard nodule was identified, but in addition to that, there were a lot of areas of fibrosis that were noted. Now the tumor was mainly retroareolar, but the resident was not sure that this, out of all this, which is the tumor bed. So this kind of way the specimen was sliced to cover the what is grossly identifiable tumor, the surrounding tumor bed, as well as the fibrotic area, just in case the tumor is extending beyond. And it is given along with the orientation of the skin and the underlying, you can make out the base. So in this way, you have to make a grid diagram, and you have to give whatever you are seeing grossly identifiable, what you think is the tumor bed, and the surrounding pale rubbery areas that were given, and accordingly the response can be measured, and the gross size can be corrected. If suppose there are residual foci of tumor in these different areas, then the T size can be corrected with the help of microscopy and grid size reconstruction. So why grid? Why grid? As I said, it accounts for heterogeneity. How? Now, if you have a tumor in which there has been a response in a heterogeneous manner, and you have sections in which you have variable cellularity, some of the sections will be more cellular, some of the section will be less cellular. If you do random sampling, so you might end up only taking sections with more response, or you might end up taking sections only with large cellularity. And in both cases, your RCB assessment or response assessment would be incorrect. So to avoid this, it is considered better that you give one full grid to account for heterogeneity in different areas of the tumor, and so you can have a more adequate representation of the overall cellularity of the tumor. So it not only estimates the cellularity correctly, you can also, as I said, do a microscopic reconstruction of T size. You can assess the adequacy of the tumor bed sampling, the extent of residual disease, and additional sampling if the microscopic findings do not match. I will show you how. So here in this grid, I could see that there is a tumor given in this way in two sections. So when the sections are taken by the technicians, they generally they are taken, in a the orientation can be anything. They are not always in the same orientation as the diagram has been drawn. So with the help of the diagram, you can join the slides together and get an idea of the size of the tumor that has been drawn, and you can check whether it is matching the what was thought grossly. You can measure join the slides in a manner that you can see how it was oriented in the grid. The same way you can join the slides, and you can measure this, do a microscopic T size measurement, and here you can see that the T size is 1.5 centimeter, and you can check whether it is matching the gross size or does it need to be corrected. Now this is another case in which this patient had which was biomarker ERPR positive tumor, which was HER2 negative. Now the pre-chemo size was given as 8 by 8 and the post-chemo as 7 by 6. But what the resident saw grossly, she was able to identify a tumor that was around 4 centimeter, grossly visible tumor. But because the pre-chemo mammo size was given 8, she took the extensive this thing and gave the ill-defined fibrotic area also in the diagram, and indicating, that this is what ill-defined fibrotic area were present along with the what was grossly identifiable tumor. And this is just, I have done a kind of microscopic joining together of the slides as they were labeled in this grade. And what I saw was that what she thought 4 centimeter, not, you can make out this blue area here, definitely this was the grossly viable tumor which we were expecting. This is biomarker positive. So not only was the grossly viable tumor seen as it was seen in the gross, but also in what she thought for ill-defined fibrotic areas, we could make out foci of tumor extending right up to here. So instead of a gross T size of 4 centimeter, the gross T size after the grid reconstruction became 7 centimeters. And the additional 2.5 centimeter we identified because the whole section was sampled as per the pre-treatment T size. Okay, and orienting and matching with the radiology and mammography. So in additional, whatever at the bottom she thought, they did not show any residual viable tumor. So the T size after grid reconstruction became 7 centimeter. Now, also this grid reconstruction helps us in accurate measurement of the extent of residual disease. Now, for example, this slice 4 here. Now, as per the grosser, I can see that what they thought is the residual tumor bed is in this area, and this is kind of the diagram I have made of this particular slide, that in this was the section. And I know that as per the grossly viable tumor bed, only this corner is showing the tumor bed, rest of it was showing fat. So that means I can discount this, and I have to give the cellularity only in this area. And I gave in this particular area, out of the area grossly visible tumor, the cellularity was 80%. Now, so in this, the tumor cellularity in the tumor bed is 80%. Now in contrast to that, if I have a grid like this, in which the no diagram has been made of where the grosser is expecting a tumor, which area, which slice, which of the sections given, there is an expectation that, okay, there is a tumor bed in this kind of area, if this kind of grid, if the properly the diagram grossly identifiable tumor bed is not drawn, and I try to assess and I see a section in which this much amount of the, the tumor is there, I will end up counting out of the whole section, this is the cellularity. So I will give the cellularity as a percentage of the whole section is only around 30% cellularity, and my RCB might be wrong if it is actually this kind of a diagram and not this. So if you have to, when you give the grid, you not only have to divide, you have to give the sections, you also have to draw a diagram into what you think is the grossly identifiable tumor bed and its orientation and margins accordingly in a grid manner. So this is how you do a reconstruction, so that you also correctly measure the extent of cellularity as per the diagram. Okay. So this is it for the post chemo response. I will be happy to take questions. So basically, my take home message for the grossing talk today is, first of all, adequate fixation, very important. Please do make it a good lab practice to have good fixation in the breast tissues. ER, HER2 are very dependent on them, and be sure that this has to be conveyed through you only to the surgeons also, that the specimen has to reach the lab in time. You have to know the clinical details before grossing. That it is not given on the form is not an excuse. You have to find out for your this thing to be able to gross properly, that what are the clinical details before you start the grossing. Talk to the surgeon if the orientation or the specimen what you have received is not clear before grossing. Report as per standardized format. Should know the clinical implications of each parameter, then only you will be able to look for it. You have to give the specimen with grid diagrams, as I said. You have to do a clinical radiological correlation for the post-NECT specimen and adequate sampling for response assessment, because if you do not go through all this, what the mind doesn't know, the eye cannot see, and you will not be able to do a good gross examination. So I thank you very much for your attention, and I'm open for questions.
Thank you so much, ma'am. That was a very well explained session. We have a number of questions over here.
Yes. Yeah, I'm sure.
So the first one is regarding cold ischemia time. Does it mean the time to put the specimen intact in formalin, or seriously slice it and then put in formalin?
So as I said, the ideally it should be put intact in formalin, and it should reach the lab within an hour, so you can begin your grossing as and when it reaches. But if a delay is expected, as I said, if a one single slice, one single cut through the posterior aspect through the tumor is enough generally for it to be fixed properly.
Okay, ma'am, next says Ackerman book says to cross from the anterior side. Which one's better?
So yeah, actually in our country, we generally go through the posterior aspect because as a standardized format, most of the places follow this one single slice through the posterior aspect because that is, generally fascia covered and easier to identify. We generally that skin cut is not, I have not seen it used in any of the centers, major centers in India. So I know that Ackerman use that, but in India generally one, and it is easier for the surgeon also, to give one single cut. If it is given anteriorly, I don't think that it would be a major difference. But what I would suggest is to have a uniformity, to convey a uniformity, so that the same kind of principle is followed all throughout in all the specimen. It is inside, that is all. I don't think that it would alter that much, but one single posterior cut is generally